I'm from the faculty of the Dalla School, and I'm very pleased to introduce Dr. Fiona Godlee, the editor-in-chief of the British Medical Journal, to talk to us about her preferred topic, which is too much medicine. I think you all know Fiona's illustrious background, has served as the editor of the BMJ since 2005, I believe, right? And in that time has very much emphasized the importance of evidence, and including contrarian evidence. Some of the controversies, I'm sure, that will come up have had an important impact in thinking about screening and in thinking about, for example, cholesterol treatment. And this morning we had a lovely breakfast to talk about broadly the directions of where science and publication is going to be. And I think you'll find this talk to be provocative. And Fiona has requested that please be provocative in terms of asking questions to her. So she's not in for an easy free lunch, so please do that. So with no further ado, Fiona, the floor is yours.
Thank you very much indeed, Trevor. Thank you. I'm just wondering how long we've got, and I'm so grateful to you for giving up your time. An hour, that's really kind. I mean, I won't talk for an hour, but it'd be good to get some discussion going. So it's interesting, the nice guy, Frank, you're still here. I just want to say, Frank, congratulations for getting this up. And when he saw my title, he said, "Oh, you can't have too much," he said. So I'm just here to prove, or at least to argue, that you can have too much of a good thing. I'm very delighted we've got Wendy here from Choosing Wisely Canada. So we'll talk. That's a whole. Canada's been a great source of rational thinking in this area. So I just want to acknowledge that, and we can talk about that at some point. So this is my mum. She disliked doctors, and I'm in your way. How am I going to get out of your way? This is my mum. She disliked doctors and tried to avoid them if at all possible. So it's slightly ironic that she married a doctor and all 4 of her children became doctors. That's me at the bottom, and my brother's not in the picture. I wonder, and my dad came from a very medical family, and he was an oncologist. And I mention this really just to say that I love doctors. I think they're great people. I love medicine. I'm a great fan of modern medicine. I use it whenever I need to, and I access it with my family. And I think it's done amazing, wonderful things. But I think my thesis is that medicine can get things wrong, and sometimes here we are bloodletting very, very wrong, and for prolonged periods of time. And we continue to do so. I think that's the point. The humility needs to be continuous. And Vinay Prasad's book is Why Medicine Adopts Ineffective or Harmful Medical Practices Only to Abandon Them Sometimes Too Late, or Why 40% of what we do is wrong. And often we don't know which 40%. That's perhaps the biggest trouble. So medicine has become very commercialized.
Want me to sit there so you don't have to keep reaching over? I'd be happy to.
Are you sure?
Yeah, I'm happy to do it.
I have to prod you.
Just glance at me when you
Cave, a round of applause for Cave there. Medicine has become commercialized, and I think we'd all agree with that, and marketized, and has taken over from religion as the thing we turn to deny our mortality. And we have allowed it to encroach into areas of our lives where it doesn't belong, where it brings minimal benefit and definite harm, turning people into patients and placing huge unwarranted costs on health systems and therefore on society. And we have to turn back that tide. That is my talk in a nutshell. So the next slide, yeah, that one, exactly, shows that life expectancy increases are stalling in many developed countries, and this was confirmed recently, if you just advance one more, in the paper just back one, published in the BMJ. And really this slide shows life expectancy at birth against cost of healthcare. And this is, if you go back one more, this is a log scale at the bottom. And you can see the United States is up here, with very small gains of about increased spending by about $7,000 per head, only gaining about 4 years in life expectancy, and those are tailing off. In other countries, Sierra Leone, the figures are about $150 per head increase in spending, gaining 15 years in average life expectancy. So greater gains at this end, really tailing off at the other end, so diminishing returns. And most of the deaths globally are now caused by non-communicable diseases. 2/3 of deaths worldwide, according to the Lancet Global Burden of Disease. And these are largely what we would call lifestyle diseases: diabetes, heart disease, lung disease, cancer, mental disorders. And I think I would prefer that we call them environmental diseases, because although they are people's lifestyles, they're actually often not of lifestyle choices. They're much more to do with the commercial and social determinants of health that are not necessarily in the hands of individuals to change. And a large part of this, forward one, doing well. A large part of this increasing expenditure is due to drugs prescribed to prevent or treat these so-called lifestyle diseases. So in the UK, which is considered to be, I'm afraid, the drug capital of Europe, this NHS survey data shows prescriptions have increased by 47% in the past decade. And nearly half of adults in the UK are on a prescription drug, a quarter on at least 3 drugs, and almost half of over 75s on at least 5 drugs. Just take us forward, billion prescriptions, 47% in the past decade. And the next slide shows, again from the same data, the number of people on at least 1 medicine and the number on at least 3 medicines. So moving on to the next one. Sorry, I've said all this. So, and this is the data from Australia, which shows the growth in prescription of cardiovascular and neurological and gut drugs over this period of 20 years. Next slide. And in the States, we've got medicine use and spending in the US, and these are drugs used to treat mental health disorders, growing since 1992 over to 2017. And then the next one is opioids. You'll see this has taken a decline since 2011, which is, this is a whole story in itself, as we know, with what's been driving the opioid epidemic, and the fact that it is beginning to tail off and people are beginning to understand the importance of actual medical prescription, part of the problem here. So we had in the UK a rather good series of television programs by this Dr. Chris Van Tulleken, the doctor who gave up drugs, where he took over a general practice surgery and tried to offer patients a drug-free, a half-hour consultation, but they wouldn't get a prescription at the end of it. And he said, as part of this, that we're witnessing a tsunami of drugs designed to prolong life. Most encounters with doctors end up in a prescription, and in the course of a lifetime, he estimated that a healthy person takes 100,000 pills. He said, that's fine, next one. He said it's important to say that some of these drugs do good, but they can all do harm. And they'd causing increased hospital admissions amongst the elderly, and there's data from the FDA about the number of deaths caused by adverse drug reactions, which I can go through. But the main drugs the main drugs in a general practice setting, in a primary care setting, are antihypertensive statins, and then indigestion remedies, painkillers, and antidepressants. And these drugs are increasingly prescribed to people at low risk, where the benefits are marginal or non-existent, and far less benefit than patients might expect from taking a tablet every day for the rest of their lives. So meanwhile, the market for these drugs is getting bigger. The next slide, please. And I should just say there's another, back one. There's another tsunami coming. So this is blood pressure statins that are for non-alcoholic fatty liver disease, which is another, as I'm sure you're all too well aware, lifestyle condition caused by obesity and all of those additional things. So just going back to that one, on the non-alcoholic fatty liver disease, it's already estimated to affect more than a quarter of adults and up to 90% of people with obesity or type 2 diabetes. And the point about this is it can be reversed, as with diabetes, by weight loss and exercise. But I heard the other day there are nearly 100 new drugs currently in development for non-alcoholic fatty liver disease, all of which will have side effects. And the market is estimated to be $1.6 billion by 2020, $1.6 billion just on this one condition. I mean, we all know that these conditions are a lot of them are linked anyway, similar remedies, similar causes. So the market for these drugs, yes, next slide, please. Oh, sorry, next slide. Back one. This is a kind of data-free slide, but you'll understand this, that as your risk of a condition like cardiovascular disease decreases, the benefits of any drug treatment fall, but the rate of side effects stays pretty much the same. So at some point, as your risk reduces, there's going to be this crossover point of not just no benefit, but actual harm. Next slide. So the market for these drugs is increasing, and this was just also to mention about genomics. So this is Ken Mandel and Ajahn Man Ray have raised this idea called biomarkup, which is that really what they're saying is because of we're using a much more detailed and sensitive genomic testing, we're actually catching a whole many more people in the net. And they say that the culture of advocacy and promotion of aggressive testing may arise when a biomarker or its sequelae yield financial benefit to drug and device manufacturers, procedure-based specialties, hospitals or laboratory testing services, or is increasingly requested by patients. And in this case, what we're seeing is because of a new biomarker, more and more people's a shift in the threshold for raised cholesterol. The bell curve effectively shifts over with many more people caught up in the diagnostic testing. Next slide, I think. Yes. So this issue about statins, which the BMJ has found itself embroiled in, perhaps slightly inadvertently, is an interesting one. And this is some coverage that in the press over the last few weeks about whether people over the age of 75 should all be on statins regardless of their risk factors. And this coverage seems to suggest... That's my daughter, I'll just have to wait. Seems to suggest that everyone over 75 should be on a statin, and it got a lot of coverage. And it was based on, next slide, this article in the Lancet, which was another output from the Oxford group, the cholesterol treatment trialist group, where they meta-analysed data looking at older patients and have concluded that there is evidence of benefit. And the editorial alongside that, although there was a question mark, did seem to suggest that we ought to be thinking about no one is ever too old to be put on a statin. But actually, when you looked at this the next click, this is from the editorial, you won't be able to see this, but it says, but in participants older than 75 years, the relative risk reduction was slightly less, 0.87. The top of confidence interval 0.99, especially among those without previous vascular disease, relative risk 0.92, with a confidence interval that spans 1. So they're really kind of saying that those very prominent headlines seem to be, to me, based on not a very, it's more of like a trend rather than a real result. And the next thing is just, next one please, looking at the numbers needed to treat. This came out of the Oxford Evidence-Based Medicine Unit, saying that if you look at the numbers needed to treat, there is, in over 75s without vascular disease, statins do not reduce major vascular events, and there really isn't any benefit in terms of mortality in those at low risk. So it's a kind of weird situation where you've got very prominent people saying everyone should be on a statin, but actually the data don't seem to me to support that. So the next slide, and this was a study, it's an observational study in the BMJ, which seemed to confirm that finding, that there really is very limited benefit, if any, in people of this age group, and of course potential for harm. So we then get on to the question about extending the definitions of disease. We've talked about cholesterol definitions, and this is about hypertension. And the term pre-hypertension, which was coined in 2003 for people with normal blood pressure, but in the higher range of normal. And based on that change, 1 in 3 adults were said to be pre-hypertensive and therefore at risk. And in this study, just going back one, sorry, back. This idea, forward one, sorry. This idea of new conditions will give medical label to people who are at risk of being at risk. So a risk factor actually becomes a condition. And we've now then more recently had the new guidelines from the hypertension, but just about the previous one, Ray Moynihan, our journalist on that previous piece, found that of those on the committee who decided on the new category, 11 out of 12 had ties to industry. And Ray Moynihan, who's in Australia, is very prominent in the debate about these definitions need to be set by people who are not conflicted in that way. But these new guidelines have defined elevated blood pressure as 130/80, so that more than half of adults aged over 45 will be labelled as hypertensive, and that's 1 in 2 adults. Now, when we had this discussion at the Preventing Overdiagnosis meeting recently in Copenhagen, the point was made, at what point will there be 1 in 1 adults? And we all agreed that that was death, that in fact we are all at risk of death, and so that was perhaps unavoidable. So the next one is about the impact of these guidelines on the rates of people who will be eligible for antihypertensive treatment. And it turns out to be 70 million in the US and 267 million in China will be newly eligible for antihypertensive drugs. And the next one is, and also a large number of people will be newly eligible for recommendations for more intense treatment. So I think you're getting the gist here. We're really talking about more and more people being caught up in the net of diagnosis, being told that they have a condition, being increasingly medicalised and offered treatments. And this is a paper published about definitions for chronic kidney disease. And the next one is this idea that actually Barbara Mintzes, who's a Canadian and rather marvellous commentator on all this, talks about not only a pill for every ill, but an ill for every pill, which is the idea that we're inventing conditions, pre-diabetes, pre-hypertension, pre-dementia, and other types of conditions in order for markets for pills to be developed. And we had an attempt in the BMJ to, you may know this story, to hammer home this idea of medicalisation or disease mongering. The date is important, April the 1st, 2006, and it was Ray Moynihan again who wrote this news story about a new condition called called motivational deficiency disorder, considered to affect 1 in 5 Australians. So serious that many of them had lost the motivation to breathe. And the great joy that a new drug had been developed called Indolabant, which had turned these sofa cripples into investment bankers in Sydney. Now, we thought this was a pretty good spoof, but sadly a New Zealand newspaper picked it up and did a big spread about it. And when they realised it was a spoof, they were very upset and sent me a rather hurt email saying that I had damaged my credibility as well as theirs, which was... but we did get a good rapid response showing that some people got the joke. Someone said, we discovered this condition 5 years ago but couldn't be bothered to write it up. So one of the problems, of course, is that we are getting much better with our technology, much more sensitive tests, and tests can be too good. And this is about CT pulmonary angiograms, and the next slide will show that what we're getting with ever more sensitive testing is an increase in incidence, which is this line, but a mortality, this is the green line at the bottom, really not shifting at all. And you can see that, when multi-detector row CT pulmonary angiography comes in, that the incidence detection rate goes up. And this can be found in the next slide. Again, this is in thyroid cancers. This is a slightly old slide in that this has apparently now been tackled. But this is in the US, where again you've got this rapid growth in incidence detection, mortality not shifting at all, and these different new techniques for detecting smaller and smaller thyroid nodules. When I say this has been corrected, I think that this takes us up to 2008 or so, but things have improved since then. And the next one shows it again in breast cancer. So we've got widespread mammography screening and this increase in invasive breast cancers, but the deaths from metastatic breast cancer are really not shifting at all. So you've got women who are being found to have breast cancer but not benefiting in terms of their survival. The next one, and when you get invited for your mammogram, those of you who are, there's no mention, very little mention about that risk of overdiagnosis and the risk that overdiagnosis might bring of unnecessary treatment, surgery, radiotherapy, and the impact of radiotherapy on your heart. So these are all problems which have led me personally not to have mammograms. But I would say that if the data change, if the tests are better, they can detect different types of cancers and show me which ones need action, or if the treatments improve so that mortality would shift from this, then obviously one would change one's mind. But for the moment, I haven't been very impressed by the data. So the same can be said of cancer, detecting smaller and smaller polyps, and the next one is just to hammer the point home about the different types of cancer we might be wanting to detect. So fast-growing and even slow-growing cancers, but when it gets to these very slow and non-progressive cancers, which screening may well also detect, this is where the overdiagnosis occurs. And this is Gil Welsh's work. Yeah. Next slide.
The snail is slower
Yeah,
than the
this-
turtle. To become accepted, this distinction, very slow.
Very,
really,
very
really
slow, exactly. And in terms of the people who are caught up in the difficulty of overdetection, this is in prostate cancer. So we've got, this is men who don't undergo early detection. Sorry, I've got this written out so I don't make a nonsense of it. Maybe I haven't. My eyesight isn't very good. So we've got men who died from any cause in those who didn't undergo early detection. But here you've got a similar number dying, but you've got these people who are men who were diagnosed and treated for prostate cancer unnecessarily, is this dark blue, and in the light blue, men who learned after a biopsy that their diagnosis was a false positive. So these are the false positives, and these are the ones who had unnecessary treatment. So that's a pretty big problem, I think, and a lot of countries, prostate cancer screening is still very widespread and often encouraged, or patients ask for it. I haven't got time to go into this vast subject of overtreatment in frailty and end of life, but I think the real problem that we face is that doctors find it very hard to know when to stop. If you ask doctors themselves what they would have in these circumstances, they're often much less willing to embark on invasive and heroic healthcare. We know that if you undergo chemotherapy for cancer, especially if it's a kind of third or fourth attempt, you're much more likely to die in hospital, and that may not be what you wanted. But the conversation that should take place that would explain that to people often doesn't. And likewise, in very frail and elderly people, the idea that we can bring in palliative care, even if they haven't got a cancer, and prevent them going back into hospital and having unnecessary treatments is something that is only beginning to be more widely discussed. Next thing. So we have too much medicine, which I think is fair to say is a combination of overdiagnosis and overtreatment, and those two things overlap with the next slide, yes. And next one is just to make the point that at the same time as overtreatment, we do have undertreatment, and they can happen even in the same country, in the same region, in the same, but some underrepresented groups of people, age groups or social class. So we have to recognise that, but equally these are linked because overtreatment can cause undertreatment, because if overtreatment is diverting attention away from the truly sick and professional attention is put on the worried well, then that's a problem as well. So this was very well put by Margaret McCartney, who, the writer in the BMJ, too much testing of well people and not enough care of the sick worsens health inequalities and drains professionalism, harming both those who need treatment and those who don't. The causes of too much medicine are complex. I wouldn't want to pretend it's a simple thing. None of us would think that. So what is driving medical excess? I think we can talk about, as I've talked about, increasingly sensitive tests, finding things that didn't need finding, expanding definitions of disease, lowering the disease thresholds, the creation of pseudo-diseases, that's the disease mongering, clinicians' fear of missing a diagnosis or of litigation, intolerance of uncertainty, which is what this article talks about, incentives to do more tests, public enthusiasm for screening, policymakers, commercial enthusiasm for screening and prevention, and then you've got patients' desires, patient pushing for more tests, financial incentive and commercial marketing. All of that is summarised in the next slide neatly by Ernest Heath, who just says a toxic combination of vested interests and good intentions. So very often, the patients, the doctors, are really trying to do the very best for each other, and that's driving it as well. But also we have got vested interests. And then there's the evidence base, which is a problem here, because what is clear to me and to many is that the evidence base has a systematic tendency to overstate the benefits of treatments and to understate the harms. And this is a review that was done in 2010 looking at reporting bias in medical research, just going back, reporting bias in medical research, and they looked across at a whole range of conditions and fields of medicine, and found in all of those they looked at this tendency for what you might call optimism bias, where the new pill is considered better than the old pill, or any pill better than no pill, or treatment. And this has been systematic in their finding. And they said that many cases involve the withholding of study data by manufacturers and regulatory agencies, or the active attempt by manufacturers to suppress publication. The effects of reporting bias included the overestimation of efficacy and the underestimation of risks of interventions. So then publication bias, the next one, is a well-known phenomenon. It's been studied over many, many years, and we know that positive studies are more likely to be published in the first place, published faster in higher impact factor journals, more likely to be cited, and indeed more likely to be published more than once, which is a bit of a problem. And the next slide shows a rather well documented example of that, publishing more than once. Again, this is old in the sense this was done in 1997, but there's other examples which show this does still happen to some extent. So this was a systematic review of the drug ondansetron, which is an antipsychotic, antiemetic drug. And the reviewers looked at the evidence base. They pulled together all the trials. And initially it looked like there were about 80 or so trials and about 12,000 patients. When they deduplicated all of that, turned out there were about 70 trials and only 8,000 patients. And when they did the difference between those two sets, the sort of undeduplicated and the deduplicated ones, you get a very different result. So this is the result that had been thought, a nice narrow confidence interval and a quite nice number needed to treat of about 5. But when they did all of the magic to find out the real result, it's a rather less certain result, and our number needed to treat near 10. So that is what you can do if you publish the positive results several times and magnify the effect. So the next one, and then obviously another problem with the evidence base is the fact that a lot of the data are hidden. We've talked about it being published too much, but this is kind of, some of the stuff just never gets out there. And the next slide shows quite a good example of this, published in the BMJ a couple of years ago, which is about another drug, reboxetine. This is a drug that well known and used this is German data. They were wanting to decide whether to make reboxetine available for treatment of depression. And the body that in Germany that makes those decisions, IQWiG, had a sense that they hadn't got all the data. So they asked the drug company Pfizer for the data, and initially they refused. So they said, well, unless you give us the data, we won't make your drug available. And so they gave them the data. It turned out that about 3/4 of the data had never been published. And again, they did the assessment of what the result looked like with published and unpublished data. And you've got 4 outcomes here: remission, response, adverse events, and withdrawal. So 2 positive outcomes and 2 negative outcomes. And under each one, we've got, with the published data, the unpublished, and then the total together. So over here, you'll see the published data on remission looks rather good for the drug, better than placebo. The unpublished data, not so good. And the published and unpublished together, no effect. Likewise with response, a good result with the published, not so good with the unpublished, no result with the total. And here on the withdrawal, it's going to be the reverse. So the published data suggests that there aren't worse problems with the drug than the placebo. Unpublished data finds actually that the drug is worse than placebo, and combined worse than placebo. So what you've got is a drug that was considered safe and effective, actually harmful and ineffective. And that's a pretty shocking result, I think. We can all agree. So one of the things the BMJ has been doing over the years has been trying to promote a drive to get access to clinical trial data, a number of different studies, a number of different theme issues on this. And we have made a little bit of progress. And I just thought I'd just tell you about the iconic, in my view, iconic story of Tamiflu, which is strangely is still ongoing, but I'll tell you where we are with this. So you will remember, I think, the swine flu epidemic of 2008-9. Countries around the world being encouraged to stockpile antivirals and vaccines. In the UK, the government asked the Cochrane collaboration to update its Cochrane review on the antivirals, oseltamivir. Yep, that's fine. And so the Cochrane reviewers thought that they would have a simple job. They'd published their review in the Lancet, and they thought they would simply just do a search, update it, reaffirm their conclusion that Tamiflu did in fact reduce your risk of complications if you got a flu-like illness. But just when they were preparing to do this, a Japanese pediatrician wrote to them and said, were they aware that the review that they'd published before had been based on these 10 trials, all of which were funded by the manufacturer, and only 2 of which had been published in full. And the Cochrane reviewers sort of, I mean, they may have been aware, but this sort of brought them up short, and they decided they would therefore try to get the data. So they asked initially the systematic reviewer, then they asked the trialists. All of those people said, we haven't got the data, you need to go to the drug company to get the data. The drug company, Roche, said they couldn't have the data, and at that point they came to the BMJ. And that led us to what turned out to be a 5-year search for the data for Tamiflu. And we did everything we could. We threw all of our resources at it. We did open letters. We published every single bit of correspondence. We did editorials. We went on the media, the wider media. And just as we were doing this, Peter Doshi, one of the reviewers, the deadline for the Cochrane review came, and they said, well, we'll publish a review, but all we can say now is we just don't know. We don't know whether this drug works or not. We are waiting for the data. So that was the interim Cochrane review. And in the meantime, Peter Doshi wrote this article in the BMJ, which on the next slide you'll see. This is the table where he talks about whether different organizations thought that it did work for influenza complications or it didn't work. And you'll see down here we've got the EMA says it does work, US CDC, Australia. Here you've got the FDA, you've got Japan, you've got the Canadians, sensible Canadians, saying it doesn't work. But the top, you may not be able to see this, but this says Roche, and that says Roche. So Roche says it does work for complications if you're in Europe, and it says it doesn't work for complications if you're in North America. So, and this website, if you went on it, said this website is only for the USA. So I mean, it's a completely absurd situation, and it only made us more determined to get the data, which did arrive eventually after lots of people saying that we could never have it because it was too difficult to do. And it arrived in just a great pile of CD-ROMs, and the Cochrane reviewers reviewed it and found in more detail that they didn't see any sign of real benefit, and also some harms that hadn't previously been documented. So the next click is just to say that in an editorial on this, our editorialist said, there is an Alice in Wonderland feel to these investigators, searching over hill and dale and among the paperwork of regulatory bodies and drug companies to put together pieces of data that should have been freely available in the first place. The next slide. And just to complete the statin saga, we're doing the same for statins. We're trying to get the data on statins. At the moment, the situation is that the major trials on statins have been done by a group of trialists, and those trialists within a kind of walled garden are evaluating them, publishing their meta-analyses, but no one else can see those data. So it's a rather weird situation, and in my view that's not sufficiently independent. I would like to, and I'm not alone, to have those data available to other researchers who could actually evaluate them. Someone has described it as a bit like looking through the Hubble telescope, and just 1 or 2 people being allowed to look and describe what they see, and all of us going, wow, isn't that marvellous? And just trusting those people to tell us what they can see. And really that doesn't really work in the modern day.
Do you think trial registration has helped or not enough?
I think trial registration has helped, but we also do know that a large proportion, about just under half of trials, should be reporting their results according to the FDA Amendment Act, and that those results are not being reported within a timely fashion. So there's a big fight still to be done. But on this particular one, there is a wonderful bit of good news which is coming through from Canada, which is that Canada Health has taken a rather more proactive view on this. And you've got a law in Canada called Vanessa's Law, which has led to a willingness to be much more open. So we are hopeful that the data from the statins trials that are held by Canada Health, because each of the national regulators has some data, will now be made available for independent scrutiny. So that's a really good bit of progress, and I think we need to put our you know, a big hurrah for Canada for being so forward-looking. So we've talked a bit about error, bias, misconduct. I haven't talked about fraud in this talk, but I suppose the question of why it matters, and if you just click quickly through these next three, we know it causes waste and harm, we know it affects public health and patient care, and really because all of these things drive this human tendency to be more enthusiastic about new drugs and new treatments. And the next slide is an example of how bad science, we know that fraud can do this, but how does error or bad science drive medical excess? And what these people did was they looked at some trials of stem cell treatments, and they examined the reports for discrepancies. And the discrepancies might be, for example, that the figures didn't quite add up, that the abstract didn't fit with the tables, those sorts of things within the report. And what you can see from this study is that of the trials which had more than 30 discrepancies as opposed to no discrepancies, the effect size was greater. So shoddy science tends to drive more towards a more positive result. That makes sense. So I think that's quite an interesting finding. It's not just random. There is a tendency to push for more optimism. So I suppose my sort of final phase on this talk is really just to say that we all agree that we need to use evidence to guide clinical and policy decisions, but there is an assumption that evidence is a bit like a commodity and all of the same quality, like water. It's available on tap whenever you need it. And in reality, this is far from the case. There is water and there is contaminated water, and it really matters which one you drink. And it's not always easy to tell. So next slide, what can we do about it? Well, we know that there are many things that drive overuse and overdiagnosis. And the next slide just gives you that detail. So we've got the culture encouraging healthy skepticism about early diagnosis. That would be helpful. These are things we can do. Health systems should reform incentives from quantity to quality of care. Industry and technology, better evaluating disease definitions. Professional training to encourage greater comfort with uncertainty. And patients and the public promoting doing nothing, or at least allowing patients and the public to ask the question, what if I did nothing? What is that as a likely outcome? And so here are some other things that we might do. We could educate patients and the public about evidence and their role in decision making, make more time for shared decision making. I think the idea that we might shift doctors' time from these 3, 5, 10-minute consultations, allow them to have longer with their patients. We may find that, this is maybe naive thinking, but we may find that their prescription bills go down if they could spend longer with their patients. So shifting money to the decision timing. Encourage conversations about prescribing and end of life. Again, what if I do nothing? Focus on lifestyle change and healthy aging. Campaign for more transparent and independent evidence for healthcare, and call for more independent evaluation and rigorous regulation of drugs and devices. And just briefly, what the BMJ is doing on this, Doug Altman was our head of our statistical advisory team until he sadly died last year. And he wrote this very important editorial back in 1994, which was subtitled, "We Need Less Research, Better Research, and Research Done for the Right Reasons." And we've got a campaign at the BMJ now about better evidence, which includes more independence, and it includes more patient involvement and more rigor and critique. And the next click is just to say that this has been pushed into a thing called the Evidence Manifesto, where there are a number of different things that we've lined up, which we hope very much people will engage with. I wanted to give a big shout out for Choosing Wisely Canada, because it is a fantastic initiative that has really helped to raise this issue amongst clinicians in particular, and to give a sense that doctors and their communities are the people who should be helping us to understand how to tackle overuse. And this has just come out in the last couple of days, I think. So I haven't had a chance to read it in any detail, but it's a 5-year report. And I think it's really worth a look. A large number of medical specialties have taken part, and a lot of really good discussions are going on, and I think this will really make a big difference. And this is now also in other countries around the world, certainly in the UK. I don't know about the States, but you've got pretty much a growing international community of trying to manage overuse of medicines. So Socrates is said to have said, the secret of change is to focus all your energy not on fighting the old, but on building the new. And the next slide is really just to throw down a gauntlet to us all. So the big question is, can we, and you have to click now, can we, and I suppose I mean you by this, can you shift effort and money away from pills and tests and onto time with patients for shared decision-making and fully informed personalised choices? Can you shift time and money away from medicalised treatment of individual risk factors and onto real prevention of the common causes of lifestyle diseases through healthy diet, exercise, sleep, relaxation, and away from healthcare, which has become an end in itself, and onto addressing the social determinants of health, clean air, clean water, housing, education, open spaces, and climate change? Because I think we'll all agree that that is where true prevention is. Not medicalised prevention, but true prevention, and really is all about health creation. And the next slide just shows my dad and my daughter, because I think we all want that for our families and for our patients. And I'd really welcome your critique of what I've just said. Thank you very much indeed. Thank you, Kabi. And there's my email address if you want to.
Let's open up to some questions.
I'm happy to get started. Thank you. That was a great talk. Very refreshing. In the list of sorry, well,
Hi, yeah, Peter, we did.
Peter Donnelly, President of Public Health Ontario. In the list of homework things that people could do, I may have missed it, but I didn't see medical journals. So I'm asking this in the spirit of a challenging question. I would contend that medical journals actually have a very important part to play here. The BMJ is clearly leading the way. But I think some of this comes down to the way in which we allow trial results to be reported. So even at the most simplistic level, odds ratios, confidence intervals, not only do the public not understand that, 90% of medical professionals don't understand that.
Yeah.
Really understand it, actually, if you challenge them. There are numbers needed to treat are a bit more intuitive, and I'm a big fan of that, because if you say to most people, well, you know, if you've got this thing, and if 400 people just like you took a statin for a year, one of you would avoid a cardiac event or a heart attack. A lot of people would walk out the door and say, tell you what, I'll leave it at that. But a lot of the other stuff is it's hard to get your head around, even for somebody who's been trained in this area. So there's something about requiring tests to be articulated in a way which is accessible, meaningful to the public and the people who directly serve them.
I think that's a very good point. Yeah, I mean, the others in the room might well have a view. I could take this off. Is it helpful, this, or should I take it off? Since we're all talking at the same level now. Oh, I'm so sorry. I've got to keep it on. So sorry. I think your point about medical journals is absolutely well taken, and I think there are all sorts of sort of drivers and conflicts that journals function within around, you know, what we decide to publish and how we decide to publish it. And I think there's a lot more we could do. The business about relative and absolute risks and numbers needed to treat, we do have a kind of policy that we will only publish absolute numbers and the numbers needed to treat, but actually in some cases it's quite hard even to get those from the studies that come through. But we should do more. I think there's no doubt about that. I mean, I don't know others in the room have any thoughts on, you know, how we could do this better, because I would really welcome your guidance on that.
Well, in submitting papers, I've written a few, and I found the best ones. I have a hard time getting published. Like, most don't get published. I've written maybe 6 good ones. And I have a real tough time. And I find that there's this relationship between the editor, the reviewer, and the submitter. And the reviewers tend to be chosen because they're within the field of the discipline, and they tend to think all alike, and they tend to be very, very, very reactionary to a novel idea, particular one that comes from someone outside their profession, which for me tends to be medical oncology, and they're very, very reluctant to accept anything that's challenging them. And yet, the editors constantly I don't know every editor in every position, but will defer. First of all, they invite the people that are the standard bearers, and then they defer to them. I'm an editor of a journal, but I like to think that the editor's role is to be a balance between the reviewer and the submitter, especially when the topic is controversial. And I find maybe 96% of the time, the editor who may not be an expert in the substance will defer to the reviewer. And I find personally that makes it really challenging to make any sort of changes in the way we think about medicine.
Well, I think, peer review is a human process and has a lot of flaws, and you've mentioned pretty much all of them. I agree with you. It can be very slow. It can be very biased. It can be very blocking of innovation. In the long run, I think we ought to be looking, and the BMJ, I hope, is heading some ways towards this, to a position where research isn't published in journals at all, and it's published in open access databases, and people can then make their own decisions about the kind of work, and that journals would then come in after the event and spread that. So I think that may be the long way in which we're heading. We are shortly to launch a thing called MedArchive, which is going to be a preprint archive. So you could always send your stuff there, have it put up in front of the public, and or not the public, but your academic peers, then there wouldn't be any delay in its distribution.
Yeah, I get at least 10 things a day for journals that are not in my area asking me to publish there, so you shouldn't have trouble getting published. But anyway, the two questions I've got, one is why the only metric of success is deaths, because there is a quality of life issue around some treatments and why that's not included as part of it. And the second is why it is so binary, because take breast cancer, which Steve is an expert in. It's not purely a lifestyle disease. I mean, I know people who have the wrong genes and they live very healthy. At 30 years old, all of a sudden they're finding themselves fighting breast cancer, and if that hadn't been picked up, they would have been dead. Whereas in this case, picking it up soon has made a big difference. So I'm just wondering why make it as binary as it is, rather than recognizing that under certain circumstances, the damage to the false positives is going to outweigh the gain, and putting it that way, rather than saying let's only go for determinants of health and just leave out the people who are unlucky enough.
Well, I mean, I hope what I was wanting to make clear is that we're talking about different levels of risk, aren't we? And I think that it's where the level of risk is pretty low or minimal within a population that we're talking about wanting to avoid people being scooped up into a health system that tends to medicalise them. But if you have a family history, or if you have symptom-detected breast cancer, which I think there's a big difference between symptom-detected and screening detected. I mean, you've got people, breast cancer experts in the room, but that would be my understanding, that we want to avoid people who have no symptoms and are at low risk from being scooped up into a health system that tends to over-detect and over-treat.
That was a great presentation, so I want to say I really enjoyed it. Just to answer your question about what we can do in terms of making data more accessible. So again, I think one of the things we can do is what we're required to do when we submit grants, which is provide a lay abstract, right? So even with your findings at the end of it, you're required to provide an abstract of your findings that is available for the public to consume and to understand. And I publish in a lot of medical journals, but I also publish in a lot of nursing journals. And nursing journals actually do this really well because they often require you to come up with 3 or 4 major points that your article in very, very, very simple language, with the understanding that this community may not be reading all of the entire manuscript, and so how can you summarize this for people who aren't going to read the whole thing? So I think that's one kind of easy way to go to, and medical journals don't often require that. The second thing
and the point that Peter's making is it's to do with the doctors are often in that sense not much better than
the doctors are not always able to understand, especially as things are relative and absolute. The second thing I want to maybe challenge you a little bit on is, I really loved your presentation and the examples that you provided, but the ideas are not new. I mean, I come from a critical health psychology background. There's a blueprint for medicalization and overdiagnosis. It's been written out to death in our field. I mean, really, there's so much out there already on the blueprint by which this happens. And the explanations that you provided are also widely available in things that have been published for 20, 30 years. The question I have is about the later part of your presentation, which is, why do we already know this? I mean, I think a lot of people in the room probably already know all the things you presented, and yet we are still repeating and repeating and repeating. So the last part of your presentation is really innovative and interesting, and how can we really develop that further? And I would add, to medical journals, we're in academia, the pressure to publish. You know that slide that you had at the end with the errors, I'm putting it in quotation marks, because we know that, to get tenure and to get promoted, you have to publish, you have to publish, you have to publish. I'm skeptical as to whether those are errors or whether those are massaging the data in order to get it. Right, so there's multiple industries, including the academic world, that are interlocking to create the perfect ground for the things that you're describing. Not to mention capitalism and pharma, right? I mean, you mentioned it briefly, but it's underlying so much of all of this.
It's funny you say I mentioned it briefly. I always fear I mentioned it too much. I mean, it seems to me to be a huge driver of this. But I think we also have to acknowledge that it's a very complex thing. I mean, looking to Wendy here, we're looking to think about all of the drivers, which include human nature and include our unwillingness to cope with uncertainty. There are many, many things that drive us to do more. But there are also incentives for individual doctors, fee-for-service and health systems that drive these kind of things. So it's absolutely not one thing, and you're quite right. And you could say, why, knowing what we do, why does this continue? Well, that's a real question. I mean, we've got to find ways to tackle those drivers. Yeah.
I agree. I just gotta say one thing about pharma. They're in our government. I mean, they're literally
Yeah.
So, I agree that human nature, I'm a psychologist, I come from that background, human nature is part of it, but there are structures that are much more foundational, that are the root of this, and those are going to be the hardest to overthrow, but the most
Yeah.
Thank you very much. That's great.
I'm leaving Prabhat to chair the questions because.
One of the I agree on how complicated and many motivators, but I want to come back to something you brought up around the patient information. So the slide you showed of the prostate cancer. I'm looking at Karen Bourne because we worked a lot on this, the patient education side together. The public thinks that more is better for many reasons, and it's extremely hard to get your hands on diagrams like you showed with, there are some, there's these for breast cancer, but we did a lot of work to see if we could find more of them because we thought they helped doctors explain what the concept that you were showing, that more people get their prostate cancer diagnosed, but then they get treated and nobody, it doesn't change mortality. What could we do to accelerate that? Because those things really help doctors in the room explain those complicated concepts in a visual way. And if we don't do that, people think, I will benefit because we have the benefit kind of mind frame. What could we do, or maybe the journals could help? I mean, how could we get more of that into the public hands?
Well, I think it's absolutely essential that we do that for these really big hitters like cholesterol treatment, antihypertensive treatment, the prostate screening, breast screening, and it shouldn't be as difficult as we might think it is. We've got a thing at the BMJ we're doing called rapid recommendations. We're doing it with a group in Norway, the MAGIC team, and we've found a way to try and lay out the decision about whether, for example, arthroscopic surgery helps in degenerative shoulder. Likewise with knees, and we find that, or they found that it doesn't, and we've kind of laying it out in a way we hope is helpful in terms of why the recommendation is that it is and how strong. So I mean, we're all playing around with trying to make this more useful, both for doctors and patients, and we're not there yet, I think is the answer. But Cabe may have an answer. Sorry.
It's obviously it can be overwhelming to think about. I mean, it's sort of like thinking about climate change. Sometimes it's just think where do we even start? But with the cancer ones are tough for sure, and it doesn't help that there are actually specialists who will disagree with everyone in the room and say, no, you have to treat this. But the statin and other chronic diseases are interesting because there, as many people know, patients often don't even take the medications consistently. So I do feel like the non-adherence problem might actually be a solution to actually get, it would save the health system a lot of money, and it would save a lot of guilt and anxiety amongst everybody. Like when you think of how many people are prescribed hypertensive medications and diabetes medications, not counting insulin, but pills and statins, and then just take them 50% of the time. And actually, you know, BMJ Quality and Safety, we've published a few papers on adherence, and actually in an interesting one we're doing now, there was one of the few positive studies when they actually did the 6 months follow-up, it was back to not working. So we are not very good at promoting adherence, and we're probably not well off to try to invest more in it because most of it's over-treatment anyway. Like, I feel like we might want to pick a wedge is what I'm trying to say and make progress on that. I feel like
How would you do that? You mean you'd
I feel like there might be more of a partnership, and there would be fewer people saying, no, damn it, you have to treat all these people. The cancer one, you'll always be able to find some celebrity who says my prostate cancer was detected earlier, my this or my that, and it'll create pandemonium to try to go up against that. But with the chronic diseases, which most patients don't even feel that they need to take them, except when they have a headache, that's when I'll take my blood pressure medication, like that type of thing. Like, I mean, then you could actually use that thorn in our side to our advantage and maybe de-escalate, demedicalize some of those, and then maybe after 10 years of doing that, we might be able to make inroads into the overdiagnosis of the cancer side. Just a suggestion.
It's a good one.
Other comments?
Yeah, let's.
Yes, sir, and then we'll come back to
Maybe a strategic question. So many examples that you gave are examples where people invested a lot of time in highlighting problems with hidden data. Think about Tamiflu, you were talking about 5-6 years. When I see how many people are here in the room, so I thought when I would come to your presentation, which is about one of the biggest challenges I think in healthcare currently, we think about the opioid crisis here in Ontario, which is huge. It's partly certainly related to your presentation. I thought this would be a packed room and a big auditorium. No, honestly,
I'm delighted.
I look at this and I think, are there enough people who are really medical researchers, people in health policy, who are willing to tackle the problem? So when you have the REAT initiative, for example, by the BMJ and other medical journals, do you find enough people who are counterbalancing the overwhelming investment in industry-funded research, which works with hidden data, with misrepresentation of data? So are you optimistic, and do you see concrete measures that we can take to mobilize more people to be involved in this?
Well,
Thank goodness for Nice, right?
Well, absolutely. For the National Institute in the UK, which is just celebrating 20 years, so that's good. I think my feeling is that people sometimes criticise, and it may be the same for Wendy, I don't know, but they criticise the BMJ as too much medicine because they're saying, well, what about too little medicine, which I do mention. But it seems to me that the overwhelming push is to do more, and therefore it seems appropriate to try to create some counterbalance to that. And to tell these stories so that we can sort of try and think of ways to create solutions. So am I optimistic? Not terribly, I have to say, but I do think that the more we can engage doctors and patients in this conversation, the more progress we'll make. I mean, the comment was made about the incredible overwhelming power of the pharmaceutical industry, and that's not going away. There was in another talk I give, there's a slide from Lisa Barrow which says that of all the new drugs put to FDA, they were all supported by only industry-funded research. So that the regulator is receiving only, there's no independent research going into that regulatory decision. I mean, that seems to me to be really criminal. And so the big push at the moment that we're working on the BMJ is to try to establish mechanisms or to come up with solutions to this, one of which is to find funding mechanisms for independent evaluation of drugs. It seems to me completely wrong that manufacturers evaluate their own products and then hold on to the information. That seems to me so wrong. It just, you can't even believe that we've allowed it. How we get away from that is a whole other thing, and it's going to be very tough to shift that thinking. And industry won't want to relinquish that, so we've got to fight very hard.
Last question.
Yeah, I think, sorry, I'll be trying to, but I think if you want a mechanism that will get you there, it's got to be more nuanced, because one of the things that's hit nice and hit a whole bunch of others is that it looks like you don't want to pay to save me because you want to save money. And you look at the whole arguments around wait times for things, and they don't say, do you need the hip replacement surgery? They're just saying, how long are people having to wait for it? So if you just put it in that thing, I think you'll run into the trouble of people thinking you're willing to cast them overboard in order to save a buck. I think if you focus on the risk benefit as opposed to cost benefit, and point out that in a lot of, at a certain point, if the risk is low enough, you are doing more harm than good, and you put it on that you're just not getting health value for what you're doing, and you know how many healthy women should have their breast cut off in order not to miss one breast cancer. I think that's more likely to take it there than talking about not medicalizing as though it's minor. But I don't know, what are the
When we take the last question, and you can summarize.
Thank you. I'm Lynn Moore, and I'm actually going to put on my patient representative hat. I really like the fact that we keep talking about the patient as a partner in the decision making, but I come back to the fact that the patient is impoverished in terms of the access to evidence. You talk about journals, what patient can actually access a journal article till it's out of date? So I think not only do we have to have it understandable, but they have to have the access to the information. And I think somebody has to start holding media accountable for how it publishes the results of recent studies. Otherwise, you're not going to have patients who are able to make those good decisions with their physician.
Thank you. I mean, I think that's a very well put. The BMJ is an open access journal, so we publish our research open access, but some of the educational stuff, which would also be useful, is not open access.
What does it cost to publish?
It costs about, I don't know the exact figure, about £3,000. Yeah. But we have waivers. I mean, all open access journals, many have waivers if people can't pay, if they haven't got funding. Yeah. But I think just on the patient thing, one of the really crucial things is patient partnership. I think we've all, we're pushing on that. We're pushing for patient partnership in research, the design, the analysis, the reporting of research. We now ask all of our authors to say how they involve patients, and it's remarkable how many still can't say that they did, and we make them say that they didn't do it. But that is shifting, I think, as a result. People are beginning to recognize that's not okay.
Great. We will have to wrap up. Do you have a few minutes?
Yeah, I'm in no hurry, but I can stay and talk.
Thank Fiona on our behalf.
Thank you very much.